Hello, everybody. I'm Christopher Klipstein. I am a professor in the Department of Medicine, and I'm here to talk to you about an inpatient ward orientation session. So here's the scenario. You're starting an inpatient attending rotation. Your team has the maximum number of patients, including 3 overnight bloods. Patients are sick and complicated. You walk into the workroom, wherever the team home base is, and suddenly many eyes are upon you. Residents, interns, third-year student, acting intern, maybe others, pharmacist, social worker. So you have 2 options. First is you can have everybody introduce themselves and then start rounds right away. Other option is you can have everybody introduce themselves and then stop and have an orientation session before you start rounds. I think we'd all agree that best would be to have an orientation session, and we all know that we should do that. And yet many times this doesn't happen. Well, why is that? I would say there's 3 reasons. One is that having an orientation session takes time. Team is busy, there's a lot to do, there's just a great temptation to just get started. A big one, though, is asynchronous rotations. The time when the attending, residents, interns, medical students all started the rotation on the same day, and the rotation lasted 4 weeks, those times are long gone. Rotations tend to be shorter, and there's plenty of times when some of the learners, the residents or students, actually started the rotation before you came on service. And it can feel a little awkward to have an orientation session when part of the team's already been on the team. And then in that situation or any situation, sometimes it can be hard to know what exactly should I say. So given those 3 things, that it takes time, people aren't starting at the same time, and you're not sure what to say, sometimes an orientation session doesn't happen. But I'm here to say that you really should have an orientation session. And why? Because that's the perfect opportunity to discuss your expectations. And part of that is to provide basic information about the rotation, about the structure of rounds, how will clinical work get done, and the plans for educational activities. But here's my key point. Almost more important than the details of what you discuss during the orientation session is just the fact that you have an orientation session. Your conscious decision to have an orientation session sends several key messages to the team. Most important is that you care about them as a team, and you're acknowledging that it is a new team. No matter when people started, you are now a fresh new team. And that as a team, you're going to be working together to provide clinical care and to teach and learn from each other. So it's not going to be just go, 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 get the work done. There's going to be a good balance between service and education. And this really helps set the tone for the rotation. And again, key point is just have an orientation session to help set that tone, that this is going to be a balance between service and education, and you're going to work together as a team. So once you decide to have an orientation session, one of the things you need to decide is, well, how long should it be? Should it be short, a couple of minutes at most, which might include basic introductions, some information about the rotation, the structure of rounds, and the key thing is deciding who's going to make the decisions. Is it going to be really top-down? Attending says, this is how things are going to be done, or is it more letting the residents make the decisions, and as the attending, you tweak things based on your preferences? Or more of a medium length, 5-10 minutes or so, or you provide more details about the rotation, more details about the structure of rounds, and really make plans for educational activities. Or it could be a really long rotation, more than 15 minutes. We're very detailed, and if it's going to be that detailed, perhaps it's better to include a handout of some kind. But the key thing is you can do what sometimes I like to do, is have a very short one to start, get rolling, make little tweaks during rounds, but then later that day, tell them ahead of time you're going to do this too. Let's now sit down and really talk about more of the information I want you to know. And having that handout, that can be something no matter what length of orientation you decide to do in person. You can always have a handout you send them ahead of time, or you give them on that first day. So which length should you do? And part of it depends on the specific of the actual rotation, the composition of the team, and you. If you're an attending who has a lot of your own personal quirks that you want things done your way, you need to have a long orientation session where you specifically tell all those details. If you're more, let's just let things sort of happen, and I'll tweak things along the way, perhaps it can be shorter. Other things that go into that are time of the year. You can obviously have a short orientation session if it's March, but if it's July, you're probably going to want to have a much longer session. Because what goes into that is the experience of the team members on that service or ward and with you as well. the residents and the students have been on there for a while, or they worked with you before, it can be much shorter. And certainly if a patient's crashing right now, you can't have a half-an-hour orientation session. But you can always just have a 1-minute session, introductions, and then say, okay, here's 2 pieces of information, let's get started. We'll talk more later. Key for me is no matter which length you have, I think it's important to say up front and then actually do it, is to say that you're going to have a separate orientation session with the students later on that day. Again, it's really important to send a signal to the students that you're acknowledging them, that they're on your team, that you're part of the team, and that you're going to talk to them more later. All right, so what information should you cover? I would say that falls into 3 different buckets. There's basic information about the rotation, there's the rounding structure, how will the clinical work actually get done, and then educational activities. So in basic information, most basic is just making sure everybody knows who everybody is. So everyone introduces themselves, and then if there are key other people you want, if there's pharmacists, nurses, social worker, case managers, key transportation people, key front desk staff, whatever it is, just making sure people know who everybody is. And then rotation-specific details and key roles and responsibilities. So on the Med W service that I attend on in medicine, the upper level resident goes to this multidisciplinary cap rounds at 8:30 every morning. So making sure that's set up front, or chemotherapy orders need to be in by 10 o'clock, or whatever the details are that are really important that must be known on day 1. And then if there are some already established educational resources that the residents are supposed to look at or ideally would look at, that's important to point those out. And if you have time, either at the start or later that day or the first couple of days, it's helpful to talk about previous experiences with the resident, the interns, the students. What have they done before? And that can help inform any goals for rotation. There's specific knowledge gaps, clinical reasoning skills, and hope for experiences like doing procedures, better ultrasound experience, talking about end-of-life things, running codes, whatnot, based on their goals. So rounding structure. We're going to talk about a lot of different things that could be decided about rounding structure and how clinical work is going to get done. But a key decision is who's going to make those decisions. Again, is it going to be top-down attending says, we're going to do it this way, this way, this way, this way, this way, this way, or is it going to be resident, I'm going to let you decide a lot of these things, but if there's something that I want tweaked, I'm going to let you know. So potential things to talk about, think about would be, does every patient need to be pre-rounded on, or are there just specific ones? And how detailed do you expect those pre-rounds to be? What information do you want the team to have before rounds start? During rounds, will the whole team see every patient as a team, or are there key select ones that you'll see as a team, and other ones that the residents will see on their own and the attending will see on your own, or maybe just you and the upper level resident will see them? And how is that decided? Is that predetermined, or every day does it depend on things? What's the path to rounds? Do you always start at room number 1 and cruise to the end? Or if your patients are scattered around the hospital, which order do you go? You should see the sickest people first, obviously, if people are crashing, but do you see flow patients first, last, and who determines that? Are rounds going to be bedside rounds for everybody, some? Who gets included in rounds? Do we always make sure the pharmacist is there, or nurses, case managers, social workers, or anybody else? Format and length of presentations. What information do you want to be in those presentations? Do you want a 1-minute presentation or 5-minute presentation? Is there any difference if it's a new patient or overnight flow patients? The student presentation is different. Is it different from an acting intern versus a 3rd-year student? Important to say what you expect. And then if you have more than one intern, while you're seeing one intern's patients, what is that other intern doing during that time? Entering orders for that patient or for their own patients, calling consults for that patient or their own patients, or are they intently listening to the presentation because they're going to need that information for cross-cover issues? And then when are consultants called? Are they called, again, while you're seeing the patient, later on during rounds, by a certain time? When do rounds end? Just when you're done seeing with anybody and everybody, and that could be whenever with a wide range, or is there a hard stop? No matter what, we're going to finish by this time. And well, then what happens as that time approaches? Is that when you decide, okay, now I'll see the rest of the patients on my own, or we'll card flip, or the resident and I will see them, whatever. Format of the notes. Is there a specific template that the division uses, the department uses, that rotation uses? There are specific little dot phrases that are important for that rotation. And is there any difference for student notes? Do you expect students to be more thorough, more complete, different formats? How should the residents and students contact you? Should they page you? Should they send you an epic chat? Should they text you? So I often give the residents my cell phone information, but I don't the students. For the students, I say, please send me an epic chat. Key thing is when to contact you. If they have clinical questions, if they're ordering a test, especially if it's expensive or very invasive, if they're doing a procedure, if you want to know about it, you want to be there. If there's a rapid response code, you want to know when it's happening or after the fact. If there's new admissions, do you want to be alerted during the day? So the key thing is just what decisions can the residents make on their own and what do you want to be alerted to? When the team's going to run the list, sort of late afternoon, early evening, or if the team's even going to do that, when the residents sign out to each other as the attending, are you part of that? Do you help direct that? When the residents and students get their days off, is that something you want them to decide? Do they just need to run that by you, or are you going to be very involved in determining that? So key thing, there's a lot of information, and clearly, unless you have a long orientation session, you can't cover all that. But the key thing is, much of that can happen organically. You just need to decide what's important to say up front, or what's important can you just let happen, and then just tweak as the rotation evolves. And the key thing is, who's going to decide that again? Top-down or more resident-driven? All right, educational activities, and it's important if you haven't done it to identify any existing resources that you think all residents should or must process during their time on that rotation. Then you have to decide when's teaching going to happen. Is it going to be during rounds, a little bit of blurbs of information during rounds, mini sessions, or it's going to happen after rounds. What's going to be covered? Is it every time you do this rotation, we're going to talk about this, 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 and this, or is it based on what the residents and students ask for? And what's the formats? PowerPoint lecture, chalk talks, little blurbs. Do you assign topics to residents and students? All important things to talk about. Important is to, it's not just the time when the attendee teaches the team. There should be discussion about when's the attendee going to have a separate session with the students. Same thing with the residents is establishing when are the residents going to teach each other and the students, and when are they going to have a separate session with the students. And then when and how will feedback be delivered for rotation-specific things, but also on their progress overall based on their medical school year and residency year. All right, so summary. My key piece of advice about having an orientation session for award service is the same as the classic Nike 1980s slogan. Just do it. Just do it. Why should you do it? It just sends a signal that you care enough to have an orientation session, that you care about the team, that you care about them as learners, not just people who are going to process these patients and as peer service, and sets a good tone for the rest of the rotation. And so you need to decide, once you decide, yes, I'm going to have an orientation, is it short, medium, long? Do I do something at the start? Do I have a part 2 later on that day or the next day? Do I have a handout? Do I send the handout ahead of time or give it to them that day? Based on all that too, and what will inform that too, is what details do you want to include and who makes the decision about those details. And then enjoy. We've got fabulous residents, interns, medical students here at the University of North Carolina. If you do all this and set the tone for a great rotation, everyone should have a fabulous time. So thanks for listening. I hope this is helpful. Cheers.